Hello and welcome back to the deep dive. Today, we're shifting gears a little bit. We are officially entering exam mode.
Exam mode. I can feel the pressure already.
Right, and we're focusing on a very specific listener profile today, someone who is right in the middle of it, preparing for the Gujarat University MD Anesthesiology exams.
Yes, that is a very specific, and I have to say, high-pressure environment. Having been on the other side of that table, I can tell you it is not just about knowing the drugs.
No.
No. It's about knowing how to present them to an examiner who has, heard the same textbook answers for 20 years. They're looking for precision. They want to see you think like a clinician, a consultant, not just a book.
Exactly. So for the next little while, I'm the student, maybe a bit stressed out, and you are stepping into the role of my senior MD faculty.
I'll do my best.
And our mission today is a high-yield, totally examiner-focused review of 3 very specific drugs: Pheniramine maleate, Promethazine, and Pentazocine.
A classic trio. A very classic trio.
Yeah.
You will see these on the table in a Viva, or, you'll be asked to write a short note on them. The goal here isn't just to list off dosages.
Right.
We need to understand the pharmacology deep enough to handle the why questions, to structure a proper short note, and to navigate those tricky Viva tables where, honestly, one wrong answer can cost you the whole station.
And to do that, we have pulled a pretty serious stack of source materials. We're talking the standard pharmacology texts like tetrapathy, or KDT as everyone calls it, and the big anesthesia books.
The heavy hitters.
Yeah, Stolting, Miller, Morgan and Mikhail, and Koshik.
Essentially, these are the books your examiners have sitting on their own shelves. If it's in Stolting or Tripathy, it's basically gospel for the exam.
Precisely. So let's just get straight into it. Part A of our review: Pheniramine maleate.
Yes. Commonly known by the trade name Avil, but, and this is important, for the exam, you absolutely must stick to the generic name.
Okay, noted. Generic name only. So, setting the scene, I'm in the exam. This comes up as a short note. I can't just write, it's an allergy drug, can I? How do I frame that introduction to grab those first few marks?
You can't. You have to start with the classification. Precision is everything.
Okay.
Pheniramine is a first-generation H1 antihistamine. And if you want that extra point, you'll add that specifically it's derived from the Alkylamine class. That's your opening sentence.
Got it.
It immediately tells the examiner, you know the drug's family tree. You know where it comes from.
And it really feels like one of those drugs that just refuses to go away. I mean, we have all these newer non-sedating antihistamines now, but Pheniramine is still everywhere in our hospitals.
It is. And that's a great point to make. Tripathy points out that while the newer agents, the second and third generations, they often overshadow the older ones in, say, an outpatient clinic.
Sure.
Pheniramine stays highly relevant in exam settings and, importantly, in emergency practice. And you should ask yourself why.
Okay, why?
Because it's available, it's cheap, and it has decades of historical precedent. So you frame it as a drug used for the symptomatic management of allergic reactions. But, and this is the key part, it comes with a very specific side effect profile that we sometimes exploit and sometimes have to manage.
Okay, that makes sense. Let's get under the hood then. The mechanism of action. This is marked as very high yield in our notes.
That is. The primary mechanism is, of course, competitive antagonism at the H1 receptor. By blocking these receptors, it inhibits the effects of histamine.
So it stops the itching and swelling?
Well, think about what histamine actually does. The examiner wants the details.
Yeah.
It causes vasodilation, right? It increases capillary permeability, which leads to edema, and it stimulates sensory nerves, which causes the itching, the pruritus. Pheniramine just gets in the way. It sits in that H1 receptor and blocks those effects.
Simple enough. But looking through Tripathy, there's a property mention here that seems almost out of place for an allergy med. They talk about membrane stabilizing activity.
Right. It sounds more like cardiology or maybe regional anesthesia than allergy management.
Exactly.
But chemically, it makes perfect sense.
Okay.
If you look at the structure of Pheniramine, it's actually remarkably similar to local anesthetics, like lignocaine.
So you're saying if I, in theory, injected Avil around a wound, it would actually numb the area?
Technically, yes.
Yes.
It would. It blocks sodium channels just like a local anesthetic does. It prevents the depolarization of the nerve membrane. That's what membrane stabilization actually means in this context.
And I'm sensing a very big but coming. We definitely don't use it for suturing.
Definitely not. And this is the why question the examiner is just waiting to ask you.
Oh.
If you tell them, oh, it has local anesthetic properties, their immediate follow-up will be, so why don't we use it for a ring block?
And the answer is?
The answer is tissue toxicity. It's a tissue irritant. So sure, it might numb the nerve, but it would also cause inflammation, necrosis, or at the very least, severe pain on injection before the numbness kicks in.
Got it. So it's a look but don't touch mechanism? It's there, it helps explain some things, but it's not a clinical tool we can use.
Precisely. Now, what about the central effects?
This is the sedation part, right?
This is the defining feature of all first-generation antihistamines. They are lipophilic.
So they cross the blood-brain barrier?
They cross it easily, and once they're inside the CNS, they block H1 receptors there, which is what leads to the sedation. But that's not all they block.
What else?
They also block muscarinic receptors.
So we get anticholinergic side effects as well.
Exactly. The dry mouth, the blurred vision, and importantly for your exam answer, this contributes to the sedation too. So in the exam, you don't just list sedation as a side effect.
You explain it.
You explain it as a central action resulting from H1 blockade in the reticular activating system, combined with its central anticholinergic effects.
Excellent. Moving on to pharmacokinetics. What are the key points an examiner is looking for here?
Focus on the routes. It's available orally, of course, but in the emergency department or the perioperative setting, we're almost always talking about the parenteral routes.
IM or IV.
IM or IV, yes.
Is there a safety concern with the IV route? I feel like I remember reading something about hemodynamic issues.
Yes, absolutely. Tripathy gives a very specific warning about this. Rapid intravenous injection can cause a precipitous fall in blood pressure.
Wow. Is that due to the histamine blockade?
No, it's likely a combination of that membrane stabilizing effect we just talked about acting on the heart and some direct vasodilation. So if you were describing how you'd administer it in a Viva...
You don't just say give IV Avil.
You never just say that. You say, I would administer Pheniramine by slow 5E injection. That one word, slow, shows the examiner you respect the drug and its potential dangers.
Okay, that's a great tip. Let's talk clinical uses. This is the core of the exam answer, I assume.
This is the core. The primary answer is, of course, allergic reactions, urticaria, allergic rhinitis, dermatosis. That's the bread and butter. If a patient breaks out in hives after an antibiotic, Pheniramine is your go-to for symptom control.
Okay. Now, I want to circle a specific scenario in red ink here because this feels like a trap. We're talking about allergic reactions. So naturally, my brain goes straight to anaphylaxis. If I'm in a Viva and the external asks me to manage a patient in anaphylactic shock, my first instinct might be to reach for the antihistamine.
And that instinct, I'm afraid, would unfortunately fail you this station.
It's really that black and white.
It is. It is that black and white. And this is a classic trap. In a high-stress scenario, both in the real ER and in the exam hall, you gravitate toward the drug you use most often. We use Pheniramine all the time for simple rashes.
True.
But in true anaphylaxis, Pheniramine is essentially useless for saving a life. It takes too long to work, and it doesn't stabilize the mast cells that are, exploding and releasing all those mediators.
So it's like mopping up the water while the main pipe is still bursting.
That is the perfect analogy. Epinephrine fixes the pipe. It stabilizes the mast cells, supports the blood pressure, reverses the bronchospasm. Pheniramine just dries the floor a bit afterward.
Okay.
You have to be crystal clear in your answer. Adrenaline first. Adrenaline always first. Pheniramine is a distant second. It acts as an adjunct to prevent ongoing histamine effects, on the skin and in the gut, but it does not treat the shock.
Right. It doesn't treat the life-threatening parts.
Not at all.
Clear distinction. Adjunctive role only. Are there any other uses I should mention?
Well, Tripathy mentions its inclusion in cough remedies. It's not really an antitussive in the direct sense, like codeine is.
So how does it help a cough?
It's the side effects. The sedative and anticholinergic effects provide symptomatic relief. It dries up secretions, and frankly, it helps the patient sleep through the night.
Which brings us neatly to adverse effects.
Sedation is the big one. It's the most prominent side effect you have to mention. It can impair driving, operating machinery, all of that. Then you list the anticholinergic profile.
Dry mouth, urinary retention.
Don't forget urinary retention, especially in elderly males with prostate issues, and blurred vision.
And the cardiovascular aspect we touched on.
Hypotension, especially with rapid IV use. That's a key one to remember in the anesthetic context.
Right. And locally. If you miss the vein.
Subcutaneous injection can be very irritating. So the rule is deep IM or slow, careful IV.
Okay, I think that's a really solid overview of Pheniramine. Let's move to Part B, Promethazine. This one feels like a much heavier hitter in the anesthesia world.
It absolutely is. If Pheniramine is a simple tool, Promethazine is the Swiss Army knife of the older anesthetic adjuncts. And for the exam, your classification is absolutely key. It is a phenothiazine derivative.
Phenothiazine. That rings a bell. Isn't that the same class as some antipsychotics like chlorpromazine?
It's related, yes. It's a first-generation H1 antihistamine, but because it's a phenothiazine, it brings a whole different bag of receptor interactions to the party. It's a much more potent sedative, it's a strong antiemetic, and it has significant anticholinergic properties.
Okay, let's dive into that mechanism of action because it sounds like it's pretty promiscuous with receptors. It seems to block a lot of different things.
Promiscuous is a very good word for it. It's like a shotgun blast to the receptors, not a sniper rifle.
Huh, okay.
First, you have H1 blockade. That's the antihistamine part. Simple enough. Second, you have the anticholinergic or muscarinic blockade. That causes the dry mouth, but it also helps with motion sickness.
Now, what about the antiemetic effect? That's what it's really famous for. That's not just from the H1 blockade, is it?
No, it is not. And this is a high-yield point. That's the third mechanism, dopamine antagonism. Specifically, it blocks D2 receptors in the chemoreceptor trigger zone, the CTZ. Both Morgan and McHale in KDT highlight this. It acts centrally to block the signal for vomiting. This is what really separates it from simple allergy meds like Pheniramine.
But there's more, isn't there? I seem to recall reading about hypotension with this drug, too.
Yes. Mechanism number 4, alpha-adrenergic blockade. Tripathi notes that this is what's responsible for the hypotension you can see with promethazine.
How does that work?
It blocks the alpha-1 receptors on the blood vessels, which prevents vasoconstriction and can lead to a drop in blood pressure. And finally, just like Pheniramine, it has local anesthetic properties, that membrane stabilization. But again, we don't use it for that because it's too irritating.
Wow. So H1, muscarinic, dopamine, and alpha receptors. That is a very high-yield list for a mechanism question.
Absolutely. You need to know all 4.
Let's talk pharmacokinetics.
Well, it's metabolized in the liver, as you'd expect. A key point from Tripathi is the duration of action. Specifically for protection against motion sickness, it lasts about 4 to 6 hours.
That's a decent window.
It's a decent window for a short surgery or, a ferry ride.
Okay, clinical uses. This seems like an exam favorite because there are just so many of them.
There are. You should start with Antiemetic. It's used for PONV postoperative nausea and vomiting. And KDT is specific. It says it's particularly effective for nausea of vestibular origin or pregnancy-related vomiting.
Of course, motion sickness.
Yes. And here is a fantastic little nugget for the exam. This one comes from Kaushik. It's called the Coast Guard cocktail.
The Coast Guard cocktail. I love that name. It sounds like something you'd order at a beach bar, but I'm guessing it's for severe seasickness.
Exactly. It's a specific recipe that was used historically and still is in some places for severe motion sickness. It's promethazine, 25 milligrams, plus ephedrine, 25 milligrams.
Okay, an interesting combination. I can guess the promethazine is there to stop the vomiting, but why the ephedrine?
Think about the side effect profile we just went through. What's the biggest issue with promethazine?
The sedation. It makes you really sleepy.
Incredibly sleepy. And if you're a Coast Guard pilot flying a helicopter in a storm or a sailor on a pitching deck, you can't be asleep.
Right.
Ephedrine is a sympathomimetic. It's a stimulant. It directly combats the drowsiness caused by the promethazine.
Yeah.
So you get the anti-sickness effect you need, and the ephedrine keeps you awake and functional. It's a brilliant piece of physiological balancing.
That is a great detail to drop in a Viva. It shows you really understand the drug interactions.
It really does.
What other uses are there?
Sedation and premedication. Historically, it was a very common pre-med to, allay apprehension before surgery. And Kaushik also notes that it potentiates the analgesic effects of opioids.
So it makes them stronger.
It makes them stronger. If you give promethazine with pethidine or morphine, you'll get more pain relief and a lot more sedation.
And there was a specific neurological use mentioned in Tripathi, wasn't there? Something about dystonia.
Yes, this is a very high-level point. It's used for Parkinsonism and more commonly for acute muscle dystonia.
How does that work?
Well, if a patient has a dystonic reaction to an antipsychotic drug, which is usually caused by dopamine blockade, you can actually treat it with promethazine.
Why?
Because of its strong central anticholinergic action. It helps restore that delicate cholinergic dopaminergic balance in the basal ganglia.
That is a very sophisticated exam point. It shows you understand the whole receptor profile, not just the anti-allergy or anti-sickness label.
That's right. That's the kind of answer that moves you from a pass to a distinction.
For the warnings, adverse effects. There is a critical warning here for pediatric patients. I feel like every single textbook puts this in bold red letters.
And for good reason. This is an absolute must-know safety warning. Tripathy states explicitly that promethazine is contraindicated in children under 2 years of age.
And why is that? Is it a
Here.
seizure risk or?
It's the risk of fatal respiratory depression. There have been documented cases where standard weight-based doses have led to apnea and death in infants. In Viva, if you even suggest giving promethazine to a 1-year-old, you are in very dangerous territory. The examiner will stop you right there.
Got it. Under 2 is an absolute no-go. What about in older patients? Any special precautions?
In the elderly, yes. Morgan warns about the increased risk of confusion, delirium, and of course excessive sedation leading to falls. And systemically, because of that alpha blockade, you have to watch out for hypotension, especially if the patient is even slightly hypovolemic.
And what about local effects?
Oh, it's nasty on the veins. Pain on injection is very common. Extravasation can cause severe tissue necrosis. Some guidelines even recommend you dilute it significantly or only run it into a large free-flowing IV line to avoid the risk of arterial spasm or even gangrene.
They call it the Finnegan burn, right?
That's what they call it. It's a serious issue.
Okay, so wrapping up promethazine, the anesthetic implications.
Be very aware of the potentiation of other CNS depressants. If you've given promethazine in the pre-op holding area, you must reduce your induction dose of propofol, and you must reduce your intra-op opioid dose.
And watch the blood pressure.
And watch the blood pressure on induction. That alpha-blocking effect can make the hypotension from propofol or the volatile agents much, much worse.
Excellent. That was very thorough. Let's move to Part C, pentazocine. Now, this is the one that I think seems to confuse people the most because it's an opioid, but it's not quite a normal opioid.
No, it's not. Pentazocine is the classic mixed agonist-antagonist. For your exam classification, you need to say it's a benzomorphan derivative.
Benzomorphan, got it.
And stolting provides the historical context here. It was introduced decades ago in the hopes of creating a powerful analgesic character that had little to no abuse potential.
Which, as it turned out, was only partially true.
That's right. But for the exam, the classification synthetic mixed agonist-antagonist is exactly what the examiner wants to hear from you.
Okay, so let's break down that mechanism of action. This is crucial because it's so different from morphine.
It is. It acts on the opioid receptors, but it acts on them differently. It is an agonist at the Kappa and delta receptors. This is what provides the analgesia, but it also provides the sedation.
And what about the mu receptor? That's the main target for drugs like morphine and fentanyl.
Right. At the mu receptor, pentazocine acts as a weak antagonist, or, at best, a very weak partial agonist. This is the defining feature of the drug.
And what's the clinical result of that?
The clinical result is something called the ceiling effect.
Okay, explain the ceiling effect for the listener. I can sort of visualize the graph from stolting in my head.
Okay, so imagine a graph. The x-axis is the dose of the drug, and the y-axis is the amount of respiratory depression.
Right.
With a pure agonist like morphine, the line just keeps going up and up. The more you give, the more respiratory depression you get until eventually the patient stops breathing. Okay. With pentazocine, the line goes up for a bit, and then it flattens out. It hits a ceiling. You reach a point where giving more drug doesn't cause any more respiratory depression, and stolting highlights this as a major theoretical safety feature.
That sounds good on paper. A lot less risk of stopping someone's breathing. But what about the pharmacokinetics?
It's well absorbed orally, but, and this is a key point from stolting, it undergoes extensive first-pass metabolism in the liver. Only about 20% actually enters the systemic circulation.
So the oral dose has to be much higher than the IV dose?
Much, much higher, yes.
And elimination?
It's hepatic oxidation and glucuronide conjugation, excreted in the urine. The half-life is pretty short, around 2 to 3 hours.
So clinical uses. Where do we see it being used?
For moderate to severe pain. To be honest, it's rarely used as a first-line agent in modern anesthesia practice, not compared to fentanyl or morphine, but it does have some specific niche uses.
I remember reading about an interesting one in Obstetrics from Miller.
Yes, that's a great one to bring up. Hirabayashi's chapter in Miller discusses using prophylactic pentazocine to reduce the incidence of pruritus, the itching that you get after a cesarean delivery under spinal anesthesia.
How does that work? Is it acting like an antihistamine?
No, it's pure receptor mechanics. The spinal opioids we use, like intrathecal morphine, they cause that intense itching by stimulating the mu receptor in the spinal cord.
Okay.
Pentazocine, being a weak mu antagonist, can partially block that specific side effect without completely reversing the analgesia, which is also mediated by the kappa receptors. It's a very clever use of that mixed agonist-antagonist profile.
It really is. Okay, now for the big one, adverse effects. This is where all the exam traps live. Let's talk about the cardiovascular profile, because this is where pentazocine really acts like the odd one out.
It's the black sheep of the opioid family in this regard.
Usually when we think opioid, we think low and slow, bradycardia, maybe some hypotension. Pentazocine, it does the exact opposite.
It does. And stolting is very, very specific here. Pentazocine causes a rise in heart rate, a rise in mean aortic pressure, and a rise in plasma catecholamines.
Whoa, that sounds more like a sympathomimetic response. Why is an opioid causing a catecholamine surge?
The exact mechanism isn't fully understood, but the consensus is that it's related to that kappa receptor agonism and perhaps some less defined sigma receptor activity. The end result, though, is a significant increase in cardiac work.
Which brings us to the massive clinical implication. If I have a patient with ischemic heart disease, someone who's having an MI whose oxygen supply is already hanging by a thread, pentazocine feels like a catastrophically dangerous choice.
It's contraindicated.
Yeah.
Explicitly. If you give a drug that cranks up the heart rate and the afterload, you are forcing that already struggling heart to run a marathon. In an ischemic heart, that is a recipe for extending an infarction.
And that's the classic Viva trap.
That is the classic Viva trap. Why is pentazocine contraindicated in an MI? The answer is because it increases myocardial oxygen demand and it raises pulmonary artery pressure. Morphine reduces cardiac work. Pentazocine increases it.
Got it. The exam mantra is pentazocine increases the workload. Morphine decreases it.
That is the absolute binary distinction you need to have locked in your brain.
Huge distinction. What about the CNS side effects? It's not the same as morphine, is it?
Not at all. It's known for its psychomimetic effects. Dysphoria, a fear of impending death, sometimes even hallucinations.
Not a pleasant experience.
Not at all. And this is attributed to the kappa receptor activation, particularly at high doses. Instead of the euphoria you can get from mu agonists, you get this very unpleasant, frightening dysphoria.
And lastly, withdrawal. This relates back to the mechanism we discussed at the start.
It does. Because it has mu antagonistic properties,
Yeah.
if you give pentazocine to a patient who is physically dependent on a pure opioid like a heroin user or someone on chronic morphine therapy, it will precipitate acute withdrawal.
It literally kicks the full agonist off the receptor.
That's a perfect way to put it. Imagine the pure agonist is sitting comfortably in the chair, which is the receptor. Pentazocine comes along, violently kicks him out of the chair, but then sits down very awkwardly itself. The patient goes from full receptor activation to partial antagonism instantly.
That sounds like a disaster in the ER.
It is. It causes immediate severe withdrawal symptoms. So the rule is you avoid it in known or suspected opioid-dependent patients.
All right, it's a lot of detail. We've covered the three drugs individually. Now let's move to Part D, comparison and exam integration. Let's try to simulate that comparison table a student might have to draw in the exam.
Good idea. Let's go through them side by side. First up, mechanism.
Okay, Pheniramine.
Pheniramine is a relatively simple H1 blocker with some membrane stabilizing activity. Promethazine is a shotgun, H1 plus D2, muscarinic and alpha blockade.
And pentazocine.
Totally different class. Kappa agonist, mu antagonist.
Okay, next category, sedation.
Promethazine causes the most profound sedation of the three. Pheniramine is moderate, and pentazocine causes sedation, but it's often accompanied by that nasty dysphoria.
Right. And the most important one for an anesthetist, cardiovascular.
This is the key differentiator. Pheniramine and promethazine can both cause hypotension, right? Promethazine via its alpha blockade.
And pentazocine is the outlier.
Pentazocine is the complete outlier. It causes hypertension and tachycardia.
Okay, so let's talk about their role in emergency and perioperative care. We've touched on the Coast Guard cocktail.
That's promethazine plus ephedrine for motion sickness. For anaphylaxis, you must remember, pheniramine and promethazine are second-line adjuncts.
Epinephrine is king.
Epinephrine is always king. And for analgesia, pentazocine is useful for moderate pain, but never, ever for cardiac pain.
Because of the increased workload.
Because of the increased cardiac workload.
Let's run through some of those common exam questions and Viva traps again, just to drill them in.
Okay. Trap number 1, the cardiac patient. The examiner gives you a case of a patient with angina or a fresh MI and asks for an analgesic. Do not say pentazocine. You will be grilled mercilessly on the hemodynamics.
Because it raises catecholamines and pulmonary artery pressure.
Correct. Trap number 2, the pediatric patient. An 18-month-old comes to the OT for a procedure. Can you use promethazine for sedation or as an antiemetic?
Absolutely not. Risks of fatal respiratory depression under 2 years of age.
Perfect. And trap number 3, classification. Don't just call pentazocine an opioid.
You need to be specific.
You need to be specific. Call it a benzomorphan derivative and a mixed agonist-antagonist. Using those specific words shows the examiner you've read the standard text and you know what you're talking about.
Okay, let's talk presentation. I'm sitting in the exam hall. I've got my pen in my hand. The question is, write a short note on Pheniramine, or maybe discuss the pharmacology of pentazocine. How do I structure a 20-mark answer on these drugs?
Structure is everything. Do not write a giant wall of text. Examiners have to get through dozens of papers they skim. You need to use headings that pop out at them.
So break it down.
Break it down. 1, introduction. Name, class, chemistry, 1 or 2 sentences.
Yep.
2, mechanism of action. This is where you can shine. For pentazocine, draw the mu and kappa receptors and show with arrows where it stimulates and where it blocks. 3, pharmacokinetics. A few quick bullet points on metabolism and excretion are enough. 4, clinical uses. List them clearly, don't just lump them together. 5, adverse effects and contraindications. This section must be prominent and clear. 5, adverse effects and contraindications. 6, and finally, and this is crucial,
What's that?
anesthetic implications. This is an anesthesia exam. You must dedicate a specific section to how this drug interacts with your world. Interaction with volatiles, hemodynamic effects on induction, potentiation of opioids, things like that.
And you mentioned drawing diagrams. Visuals help.
Always. Drawing the ceiling effect curve for pentazocine plotting respiratory depression against dose is an incredibly high-yield diagram. You show a curve that rises and then plateaus, whereas a pure agonist curve just keeps going up. If you draw that, the examiner knows you understand the core safety profile without even reading a word of your text.
That's gold. Okay, we're nearing the end of our session. Let's do a rapid-fire recap for the listener to take into the exam hall. The absolute must-knows.
Let's do it. Ready?
Ready.
Pheniramine, first-gen H1 blocker. Has membrane stabilizing activity, but it's irritating. Used for allergies. It's an adjunct in anaphylaxis, never first line. And watch for hypotension on a rapid IV push.
Next.
Promethazine. It's a phenothiazine, the Swiss Army knife. H1, Muscarinic, D2, and alpha blocker. Great antiemetic, great sedative, treats dystonia. Remember the Coast Guard cocktail? And it's absolutely contraindicated in kids under 2.
And finally, pentazocine.
Pentazocine, mixed agonist-antagonist. It's a kappa agonist, which can cause dysphoria, and a mu antagonist, which can precipitate withdrawal. It increases heart rate and blood pressure, making it bad for an MI, and it has a ceiling effect on respiration.
Short, sharp, and essential.
That's it. One final piece of advice, if I may.
Please.
Visualize these mechanisms. When you're sitting in that exam hall, close your eyes for a second and imagine the receptors. Imagine the promethazine molecule physically blocking the alpha receptor and causing the blood vessel to dilate. Imagine the pentazine hitting the kappa receptor in the brain and causing that dysphoric feeling. If you can see the mechanism, you can derive all the clinical effects and side effects logically.
You've got the content, now structure it well. That seems to be the mantra for today.
That is the mantra.
Before we sign off, here's a provocative thought to leave you with. We talked a lot about pentazocine, a drug that was developed specifically to be the safe analgesic, the non-addictive opioid. Yet, as we've discussed, it causes dysphoria and it dangerously increases cardiac work.
It's fascinating, isn't it? It really reminds us of this constant search in pharmacology for the Holy Grail. A powerful analgesic with zero addiction potential and zero respiratory depression. Pentazocine was a step on that long path, but it just perfectly shows the trade-offs we are constantly forced to make.
Right.
We traded some addiction potential for dysphoria and cardiac stress. It really highlights that in pharmacology, there is very rarely a free lunch. Every single receptor we touch triggers a whole cascade of consequences. Some we want, and some we definitely do not.
A very sobering thought on the evolution of our specialty. To all our listeners who are preparing for the Gujarat University MD anesthesiology exams, good luck. You have done the reading. Now go in there, visualize the receptors, watch out for those traps we talked about, and crush it.
You have the knowledge. Now go and apply it. Good luck.
We'll see you in the next deep dive.